Today, we're so excited to be able to have Dr. CJ Berg with Access Spine Clinic out of Columbus, Ohio, on with us for our second podcast of Back and Brew. We're going to talk everything spine, everything from Dr. Berg treating someone with an AK-47 shot to the head, all the way to the very innovative ways that he is really expanding his business, not as just a neurosurgeon, but into real estate and everything else. This guy is the pinnacle of entrepreneur surgeon that every private practice physician should aspire to be. This is Back and Brew. Dr. Berg, thanks for coming back. Great to have you back in Colorado. Thanks for coming on Back and Brew. It's been probably like 2 years? A year?
No, it's been about a year, I think. Right?
Okay. All right. Yeah.
Yeah. I think it was about a year ago that we came out here and shot some videos.
Did some videos and stuff like that. And overall, kind of how's the reception been from that?
Amazing.
Yeah.
Yeah. Actually, I've had a number of patients. I've actually had a number of even referring docs comment on my video content. They love it. Like just not just the content, yes, the production quality, like all those things. It's super well received.
Awesome.
Yeah.
Awesome. We love to do that. As is tradition, this is Back and Brew. So we're talking all things spine over a brew of the guest's choice. Mm-hmm. Tell me about the brew you brought from Columbus today.
Yeah. So the brew I brought is, the name of the beer is called Lumiere. It's from Edison Brewing, which is a small microbrewery in Columbus, actually kind of right around the corner from my office location. Lumiere is a bière de garde, which is a French beer. And this in particular is a small batch of the Lumiere that is actually aged in Sauvignon Blanc barrels.
Interesting.
Yeah.
How'd you come on this? How'd you find this particular brewery?
Yeah. So very interesting, almost by random chance, to be honest. So when I was working in the military, and kind of getting ready to finish up my career in Dayton, Ohio. As I was finishing up my military career, I knew ultimately I was going to be opening up Access Spine Clinic in Columbus. That was the plan. That's what we were working on, right? But in the process of getting started, I had to find office space. I had to, kind of get everything off the ground first. So I was actually traveling out to Columbus to look at what is now my office. And I had an appointment with my real estate agent and the seller's real estate agent at 5 p.m. that day. So I happened to get out of surgery a little bit early, figured I'd beat traffic, and kind of drove out to Columbus a little bit early. Ended up getting to the area at like 3 p.m. So I had a couple hours to kill. And I just kind of decided to look for a place I could grab a cup of coffee, grab a beer, something just to knock out 2 hours. And this place is about a half a mile away from my office. So I found it, just went to go scope it out, and I absolutely love the place. I mean, it has great beer, yes, but the setting is phenomenal. I mean, it looks over the Columbus skyline, just amazing views, great vibe, great environment. And so still to this day, I go there all the time now. But that's how I found it. It was just very random. I happened to get out a little bit early and just needed a place to sit and chill for a couple hours. And that's how I stumbled across it.
Oh, interesting. So what, cheers first off.
Yeah.
And what is this beer exactly?
So it's a bière de garde, which is a French beer. So this brewery specializes in European beers, right? So they don't have a lot of American options. And in fact, the American beers they have, like IPAs and stouts and porters and things like that, are all guest beers for the most part. So they specialize in all these European brews. So it's going to be a lot of, it's Hefeweizen, Dunkelweizen. They'll have ESB, Bière de Garde, Berliner Weiss, Belgian triples, things like that. All European brews. And that's their brewmaster and owner. That's kind of his thing. That's sort of what he does. That's what he specializes in. So, which is very, in my opinion anyway, very unique, right? It feels like most microbreweries don't do that kind of thing, right? They don't have that sort of specialized, kind of this is our niche, right?
Yeah. They try to do everything.
They're kind of all over the place.
Yeah.
Right?
Let's do everything.
Yeah. So that's what he does. And they almost always have at least one or two small batch options like this. Where they'll age it in bourbon barrels, or they'll age it in, this is Sauvignon Blanc barrels.
You can definitely get it. Like, you can definitely tell that there's like a Sauvignon Blanc kick at the end of it. It's fantastic.
Like a wine. It tastes like a wine, right?
It's really good. Like looking at it, you're like, oh, it's really dark. It's going to be super heavy.
Right.
Like, no, this is actually really good. That's interesting. And it kind of makes sense. Like it's pretty light. Like you talked about how, it's kind of a good spot to sit and have happy hour beer, overlook the city, watch the sunset.
Absolutely.
It's interesting too, because like whenever I think of the Midwest, I think of like, it's a weird kind of cultural area where it has like a huge European influence.
Sure. Yeah,
So it
absolutely.
totally makes sense. Here in Colorado, we have a ton of breweries. Everyone has a microbrewery.
Yeah.
And you're right. Most of them have, 30 different taps, 30 different types of IPA, and like they're all over the board.
Right.
I can always appreciate and commend someone for committing to something like
Right. And different, right?
different. Yeah. Not easy. Different.
No, right. Exactly. Yeah. So I mean, it's kind of my go-to spot anymore. Like I said, they have a really good beer selection all the time. And his, their small batch options are always phenomenal. They also have, oddly enough, they have a really, really good whiskey selection. And they usually have like 4 or maybe 5 cocktails on their menu, and their cocktails are always phenomenal too.
Wow.
So, you can kind of take anybody from any crowd there, and there's something though. The other thing, I always enjoy too is they almost always keep either a birch beer or a root beer on tap. So like I can take my daughter there. She loves it because she can actually go to the bar and order something, and they pour it for her, and they give it to her in a pint glass, and
it's just like a root beer.
She feels like an adult.
Beer.
Yeah, it's a non-alcoholic root beer, but she loves it. She feels like an adult. She feels like she's ordering from the bar. So yes, yeah, it is a really cool spot. Lots of live music, food trucks. Yeah, super fun.
It's crazy to see like Columbus now is just blowing up. Yeah. Like I'm actually, dude, I look forward to hopefully at some point hosting an event at Edison Brewery where it's like where you can have the referring providers come out, have some beers, eat some from some of the food trucks, and learn more about Spine, and kind of again kind of establish yourself even more so in that community, which you've done a great job doing. Which I definitely want to get to that in this episode of. You are a very unique surgeon in that you play the 5-year game better than 99% of the neurosurgeons out there.
Trying to.
Doing it, it's kind of like, it's funny. I remember someone saying, they're like, the first step in doing is trying, right?
Sure. Yeah.
And so like, how do you become an investor? You start investing. Like,
right.
You when we met with you right away, you knew, you're like, I don't know if this is the right way I'm going to do it, but I'm going to do it. I'm going to try it.
Right.
And like, we absolutely love that from the Darkwater side.
Yeah.
So, but let's go back a little bit. Kind of tell me where you're from. What put you in Columbus?
Sure. Yeah. So, originally from Akron, Ohio, kind of northeast corner there, just probably about 30 minutes south of Cleveland, where LeBron James is from. So, I'm Ohio born and bred, right? Grew up there, graduated high school there. Love Ohio. Absolutely love it. I know it gets there's a lot of jokes and memes and things out there about, Ohio, but I never wanted to be anywhere else. Love it. So I grew up there. I came out to Colorado. I graduated from the Air Force Academy in 2003. Spent 4 years outside of Ohio. Loved my time in Colorado. And then went directly from the Air Force Academy, actually got special permission to go to medical school. So went back home, went to Ohio State for medical school. And then once I graduated that, I actually did my neurosurgery training up in Buffalo, New York, which I also loved. I think it's a very, very underrated town. Also gets kind of a bad rep because of all the snow, but loved it. Loved it. Absolutely. I have nothing bad to say about Buffalo. It was amazing, amazing time there. And then, because of my time in the military, I actually had to pay them back. So as soon as I was done graduating residency, got, pulled back into active duty. And ended up back, oddly enough, in Dayton, Ohio, right? Joined the Air Force, traveled the world, and end up 3 hours from home. So I ended up in Dayton, Ohio, did a full career there, did 9 years, served out my commitment, had a good time. I feel like, left that site better than I found it, which is, always, that's a source of pride for me. And, I always try to make sure I leave things better than when I got there. So I did that. And then, like I kind of mentioned earlier, I kind of knew towards the end of my career that I wanted to go in a little bit different path than a lot of my colleagues do. And whether that's, you can call it like entrepreneurial spirit or just oppositional defiance disorder. I don't know. Like I worked for the man for so long. I was like, no more. Like, so I knew, getting towards the end of my career, I didn't want to work for anybody else. Right. I wanted to do it myself. I wanted to build it the way I wanted to build it. And I do think as time has gone on and as healthcare has become more consolidated, meaning, it's bigger hospital systems. It's larger insurance carriers. Insurance carriers are now buying hospital systems. They're buying large group practices. Everything is kind of we're heading into this era of like vertical consolidation. And I think the patient-doctor relationship suffers significantly, because it's easy to become kind of a widget when you don't have any personal vested interest in, other than just your own personal pride in your job, right? But there's no financial stake in how the company's doing. There's no need to kind of create that special experience for patients. And it's easy to just look at it as a job. And I didn't want to do that, right? So I knew I wanted to kind of create my own thing. And so that's how I ended up in Columbus. I kind of, you can do your own thing in a rural setting because you end up being kind of the only shop in a large area, but that didn't appeal to me as much. I loved the city of Columbus from the time I spent there in medical school. I knew I wanted to go back, and I identified, Columbus is a relatively unique environment because it's a large city, but it still supports private practice. And there's not a lot of large cities that do anymore. Most require employed contracts. So
that's interesting. It's kind of an interesting point that you bring up there is, what do you see? So you're talking about how like there's the vertical integration and consolidation,
Yep.
right?
Yep.
And then there's still some of the gluttons for punishment like you that understand the importance of private practice and honestly the importance it is to the patient individually. They're not getting lost in a big system.
No.
They're not another cog in the wheel. Like they're just not another number.
Right.
Where do you see private practice going in the next 5 years, or even healthcare in general,
right,
going in the next 5 years?
That's a great question. I don't know. There's a lot of competing forces right now, right? So when the Affordable Care Act came out in 2008, which did a lot of good things, right? I mean, I think in the end that law has overall been a net positive, but there have been some fairly significant drawbacks to it. And one of those drawbacks was it really pushed for consolidation of healthcare resources. And so you've seen this steady march since 2008 when the Affordable Care Act was passed. You've seen this steady march away from private practice. And you've seen people get bought up by hospital systems, and you've seen insurance companies having more power than ever before to influence the patient experience and influence the care that patients are able to receive. And it was never intended to be that way, but it's sort of these second and third order consequences of some of the clauses in that law. And so you've got that, right? So that's one kind of set of forces that is really pushing people away from private practice. It's a challenging environment. And then COVID hit. And I think a lot of my colleagues started to recognize how little power they had. You started having large hospital systems who just went to the physicians and said, we're going to cut your pay by 50%, right? We're not making the money. We're not, this is a global pandemic and, we're all in it together, right? And all of these things, which is all, that sounds great. And then you're telling people that they're going to take a 50% pay cut. So I think a lot of my colleagues kind of saw that, and some have really pushed back against it and really realized that, we need to start clawing back some of that power that we've lost, right? And for not only for our own sake, but also for the patients. The consolidation. There are very few industries anywhere where decreasing the competition improves the service, right? So I think people are starting to open their eyes a little bit, And so you've also got that. So I don't really know where it's going to go. I wish I did. But I think there's some competing forces, and it's just, I think it's going to take people realizing that while this is hard, it is doable. And if you just build it the right way, you don't have to compromise anything. You don't have to chase dollars. Dollars will come. And you can still provide good, solid patient care in a way that medicine is meant to be provided, rather than in a way that corporate is looking for you to provide it. And that's why I will never go employed.
Yeah. Like, you don't want an MBA telling you what you can do, what you can and can't do in surgery.
Right.
That's crazy.
mean, this surgery reimburses better, so we need you doing more of those surgeries. Well, that's what if they're not indicated? Right.
That's crazy.
Right. But those are the conversations that happen, And
the patient sees none of this.
None of it. It's all behind the scenes. Right. And I like to think, I obviously there's some personal bias in here, but I like to think that in general, my colleagues have patients' best interests at heart. Right. But it's very hard not to be influenced when you've got somebody chirping over your shoulder,
who's also writing your check,
check, threatening your job,
yeah.
Like all these things. And it's very hard not to be influenced by that, And so maybe that patient who's a little bit on the fence of, do you need just a decompression or do you need a decompression infusion? Maybe they get the fusion, right? Whereas I can look at this and say, no, I'm not being influenced by anybody other than my own experience and my own education, right? And if I don't think that's the right surgery for you, guess what? You don't get that surgery,
How dare you?
How dare you?
How dare you?
Right. So, like I said, I think there's some competing forces. I don't know what's going to win out ultimately. I would love to see. So my goal, and I say this all the time.
I'll have you get just a little bit closer. There you go. No, you're fine.
Yeah, sure. Yeah. So right now nationally, around 87% of neurosurgeons are employed, hospital employed.
87%.
87%. So 13% of us are private. I would love to be able to flip that number, right? You're always going to have some employed, sure, right? Who are doing, the hard cases that, they're regional referral centers. They're the Ohio States. They're the Barrow Institutes. They're doing the cases where the average neurosurgeon just doesn't have the skill set to do that case. This is a 1 in 150,000 type patient where you need specific special expertise, and those people need to be on employed contracts because you can't expect them. They're doing these cases nobody else can do, right? And so they have to be able to just sit back and do what's necessary without worrying about how much am I earning, how much am I producing? So you're always going to have some employed. It's not reasonable to expect that there will ever be 100% private practice, right? But that should be a relatively small number, and the rest of us should be working for ourselves.
So I would agree. And again, being a rep and distributor, mm-hmm, I've heard a lot of horrible ideas, business ideas from some of the smartest people I've ever met, right, which are usually surgeons. And that's what's unique kind of about you that I enjoy having our conversations, even when we text back and forth about just the ideas around the business of healthcare, mm-hmm, because it seems like the business of healthcare actually drives the innovation of healthcare.
Oh yeah.
Like you go to some of the community hospitals, especially specifically here in Denver, they can't use the latest technology.
Correct.
Like they are barred from using it because it's, mm-hmm, too expensive. Mm-hmm. Whereas you go to, Texas, for example, where it's the surgeons still can own in the hospitals some of the latest and greatest cutting edge technology.
Sure. Yeah, absolutely.
That they can use, no questions asked. Surgeon gets to make the decision on what they use. And it's funny being in Texas and seeing that. I'm like, that's the most sustainable, mm-hmm, model for the patient that I've seen anyway.
100%. Yeah. And even getting outside of like the physician owned portion of that, most of recent innovation, especially in spine surgery, but really in almost all surgical fields, most of the recent innovation has been really focused on the outpatient side, right? It's been what's really driving innovation is getting people to not have to stay in the hospital, right? I mean, spine surgery 20 years ago, you were staying in the hospital for a week afterwards, right? And you were on PCA pumps, and you were, all of these things, it was a big deal, right? I mean, and that actually generated a lot of money for hospitals, right? Those long hospital stays make a lot of money for the hospitals. But all this innovation now is pushing things more into ambulatory surgery centers, right? I mean, at this point, fully 80% of my practice is done in an ASC.
That's fantastic.
Right.
And explain kind of the ASC side of it. How does surgery in the ASC benefit? How does surgery in the ASC benefit the patient?
Right. So first of all, it's usually a cleaner environment, right? There aren't sick people in ASCs. It's a surgical center, right? So you don't have patients coming in with pneumonia. You don't have patients coming in with, you are there for one reason, and that is to have surgery and then go home, right? So you don't have the same, it's a more sterile environment. It's a cleaner environment. Not that that's, any fault of the hospitals. It's just a fact, right? There's patients in the hospital who are very sick. And you don't have that in an ASC. So if this is an elective surgery, it is a better environment for that. Secondly, the costs of those surgeries, if you have the same surgery done in a hospital versus an ASC, the ASC will charge around a third of what the hospital does.
So it is 66% cheaper.
Yes, on average.
To have the surgery done at an ambulatory surgery center as opposed to a hospital.
The exact same surgery. No difference. But insurance companies pay a premium to hospitals. Because what's happening, in essence, is the operating rooms at a hospital subsidize the care that occurs everywhere else in the hospital. So you get a premium. I should say the hospital gets a premium from insurance companies for surgical care, right? But the exact same surgery, a lumbar decompression. Lumbar decompression done in a hospital will cost 3 times what a lumbar decompression done in a surgery center costs. And where that's relevant to patients is as we move into this new era of insurance coverage where premiums are constantly increasing while at the same time deductibles and out-of-pocket costs are increasing, that cost is immediately transferred to the patient.
Jeez.
Right? So if you have a 20% coinsurance, if that's part of your insurance plan where you have a 20% coinsurance and you are required to pay 20% of that bill. If that bill is $120,000, you have to pay 20% of that. Or if that bill's $40,000, you got to pay 20% of that, right? If you're getting the same surgery, I think most people would choose to pay 20% of $40,000.
Absolutely.
So that's where I continuously have this conversation with patients because a lot of them, I shouldn't say a lot of them, some of them have this kind of impression that ASCs are kind of almost like a gimmick, right? Like it's a thing that surgeons like to do, but ultimately better care in the hospital. And it's not accurate necessarily. Obviously, patients who are very ill, patients who need more intense care need to still be done in the hospital. There is still a role for hospital care. There are surgeries that require an inpatient stay afterwards still, right? They can't go home the same day. But there's a lot of surgeries where you can go home the same day. And I have even started to push the envelope a little bit on some of those surgeries where I actually partnered with a home health agency kind of in my area. And so what I'll do when I have a surgery that's more sort of on the fence of somebody who potentially could stay in the hospital versus being able to go home the same day, what I'll do is I'll get them set up with home health afterwards. We'll do it in an ambulatory surgery center. They go home the same day. Home health nurse comes out to see them the next morning, checks on them, does a well visit, calls me if there's any concerns. If there aren't, then they get about a week worth of home physical therapy after that. And patients love it. I mean, they're able to recover in their own bed. They're able to eat their own food. They're not eating hospital food. They're comfortable. And then they have a physical therapist coming to their house to work with them. It's great. And it works great. And they do well. I mean, it's all good things.
It's kind of concierge care.
It really is. It really is. And that's where innovation is going. Innovation is driving everything in that direction. Shorter hospital stays, ambulatory surgery center stays, those kind of things. That's the drive. It's unheard of anymore for a surgery to admit a patient, after a surgery, have a patient admitted for a week. It's unheard of.
Yeah.
It just doesn't happen anymore. And like I said, 20 years ago, that was the norm.
Jeez.
So, that's where all this technology is moving. It's all moving to the outpatient center because it's saving costs.
And it's funny too, from a rep side, distributor side, where we see the pricing between hospitals and ambulatory surgery centers. It's far more profitable for us to do cases in ambulatory surgery centers,
right?
Because our prices are slightly higher there than
Really?
in hospitals. Yeah, but the funny thing is the net cost is so much less to the patient and to the system.
Yep.
So it's kind of like the ambulatory surgery centers really do a good job. It's a way to cut out a lot of the fat that you don't need for 90% of the surgeries.
That's a great way to put it. Right. There's not typically a lot of, bloated sort of office staff, right? They're usually relatively lean operations. So it's interesting that I actually did not know that. So it's interesting that you actually make more money at a surgery center. So I mean, that's even better, right? Everybody's doing well. You're making more money. The patients are doing better. And that additional, profit that you're generating is not being translated over as an additional cost to the patient, which is awesome. The patients are paying dramatically less while you're making more money. That's fantastic, right? I mean, that's the whole goal. Everybody makes money and none of it gets passed on to the patient.
100%. There are hospitals that reps will not go support cases in because they're like, dude, the pricing's so low.
Can't make money.
That you I will lose money if I go cover that case.
Yep.
And that's again why we push so hard on surgery centers, is because from a pure financial perspective, we're like,
right,
we're getting 30% premium over what the hospital is next door. And I will argue too, a much cleaner process,
of course,
of getting purchase orders signed and paid for or assigned, as well as being able to even check in trays is so much easier.
Right.
Instruments don't go missing.
Right.
And again, there's some hospitals that are fantastic at managing that.
Of course.
But overall, I would say the surgery centers are
right. But that's the norm at a surgery center.
Correct. That's the norm.
Right.
Whereas that's the exception at a hospital.
Fair enough.
Right.
Yeah. And I think part of that is all driven by, the way surgery centers make money is by doing more surgery, right? So their whole focus is how can we be as efficient as possible, right? You're not dragging these things out. You're not waiting till the end of your day to clock out and go home. It's, hey, we have 5 cases. If we can get those 5 cases done before noon, everybody gets to go home, right? The hospital staff is there. Doesn't matter.
Punching the clock.
They're punching the clock.
Yeah.
They're there till 4:30, 5 o'clock, whatever the case may be. If they can, if you have 5 surgeries and they can manage to only get 2 of them done before 5 o'clock, they get to go home, right? The surgery center staff is, if I can get Dr. Berg done by noon, now I get to go home at noon.
Yeah.
Right. So everything is built for efficiency. And yeah, I mean, I prefer working in surgery centers. I mentioned 80% of my practice right now is ASC. Right. So I love it. It's a much better environment. The patients love it. Patients do great. And that's where everything is migrating into that space right now.
When you were in the military, you did a few tours, right?
Yeah.
What was your 2 tours? So what was it like operating while you were on these tours? Like, what did you see?
Interesting. It really wasn't dramatically different. I'll say, so I was at Bagram Air Base in Afghanistan.
Really, the question is, what does neurosurgery look like in Afghanistan?
Right. So yes. So the hospital, it looks, I mean, I could, if I could blindfold you and transport you to Afghanistan right now and just drop you in, so the hospital there is called Craig Joint Theater Hospital, right? And Bagram is actually closed now. Now they're pulled out of Afghanistan. So, but CJTH, I could drop you right in the middle of the hospital. You would never know. I mean, it looks like a hospital, right? You would never know you're in Afghanistan. You would never know you weren't in the US, right? Wow. It looks like a hospital. So that aspect of it's really not any different. The care we were providing out there was not any different than the care we provide out here. Some obviously exceptions. It's a war zone. It's a war zone. So we're seeing war injuries, which are obviously different than even, the traumas that we see out here. A sniper bullet from an AK-47 is completely different than a 9mm round, right?
Yeah.
So, so I was seeing different injuries, but the care you provide is much the same. The difference, the real major difference, comes after surgery, right? So you take care of these guys, troops, or local Afghans, or whatever the case may be. You do surgery on them, whatever it is. If they're American troops, they would be on a life flight back to the U.S. the next morning. Doesn't matter how sick they are. Doesn't matter what's going on. The goal was, even for catastrophic injuries, nobody dies in country, right? So we would stabilize them. We would get them to a point where they were able to fly, and then they would fly out, right?
Okay.
So there's really no, we wouldn't follow them, right? You operate and then they're gone.
They're gone. Yeah.
They're gone. But I mentioned I did 2 tours. The first tour I did was in 2014, 2015. And it was still kind of in the, I would say more just starting to be kind of the tail end of the conflict over there. And so we still had a humanitarian mission out there. And that was one of my favorite experiences. We were seeing local Afghanis, and doing elective surgery, on people who otherwise had no access to a neurosurgeon. It was awesome. I mean, I'm trying to think now. I did, off the top of my head, I think 6 or 7 pediatric brain tumors.
Oh, wow.
When I was out there. Because otherwise, I mean, there's no option.
Yeah.
Right.
The kid just dies.
Just dies.
Jeez.
Yeah. So, really good work out there. I mean, I really enjoyed my time. If I didn't have, I actually deployed the first time I left the U.S. on my daughter's 2nd birthday, which was really tough. But so if I didn't have my daughter kind of waiting for me back here, I would have actually volunteered to stay. I loved it out there. I loved it. Yeah.
Was it, so again, coming from a father too, having a daughter and leaving a 2-year-old in the U.S., going over to Afghanistan, and operating on children there.
Right.
That had to have been
oh man,
that had to have been rough.
It was rough. Oh, it was rough. Very rough. Yeah. And I can't tell you the number of times I'd get her on FaceTime, and she's 2, right? She can't really, her attention span is minimal at best. But I'd get her on FaceTime, and I would just sit there and watch her play. You don't have to talk, nothing. Just I'm just sitting there with a phone on my face, just watching her play with her dolls or something. She's not even talking to me. I don't even think she realizes I'm on the phone. But that's, and and thank God for FaceTime, right? I don't know how people did it. 10 years ago, before the advent of all of that technology, crazy. Crazy. I couldn't have managed, and I was so, because that age is rough, right?
Yeah.
And I was so terrified that when I came back that my daughter wasn't going to recognize me, or, because it's 6 months.
Yeah.
I was there, and actually I ended up being there for 8 months the first time. So, she's 2 years old when I deployed. 8 months. I mean, that's almost half of her life again that I'm missing, right? So that was it ended up being a completely baseless concern, right? I came back, and she they actually have a video of her, my parents brought her to the airport, and as soon as I kind of deplaned and I was walking down the hall, she ran past the security gate, and just this little 2-year-old just toddling out there. Yeah. So that's clearly awesome. not a valid concern on my part, but I was really worried the whole time I was out there. I was like, am I gonna head back, and I'm gonna have to reestablish my whole relationship with my daughter? But I didn't. She's great.
That's insane.
Yeah.
I just couldn't. Yeah. That would be, it would be weird being away from your kids. The people that deploy, I have so much respect for them, because I'm I couldn't imagine being
it's tough.
Gone for I go on work trips for a week, and I'm
right.
I'm man, I wonder what my kids are doing.
Right.
So I kind of talked more about specifically when injuries of war for a neurosurgeon, the mechanism of injury,
right.
what do those look like? What are?
Yeah. So I mean, the big difference in war injuries versus like civilian trauma
Yeah.
is just the force. It's the force, right? You know, a 9mm bullet does not do the same amount of damage as a 7.62, right? It just doesn't. So, and you know, there's some really great videos out there on YouTube of like ballistic gel, you know, just watching, you know, a sniper round from an AK-47 go through ballistic gel. So when you have a penetrating head injury, the injury is not, well, I mean, the penetrating injury is a problem, yes, but the majority of the injury actually comes from the concussive blast.
That's
right?
behind the bullet.
It's behind the bullet.
Yeah.
Right. And so the force generated by a 9mm bullet is orders of magnitude less than a rifle. Right. So that's the major issue. They're significantly more damaging. The other thing too, I mean, I'll never forget. I actually treated a guy in Afghanistan, an American soldier, who took a sniper round to the head. He was wearing his helmet though. And so he had an epidural hematoma and a skull fracture. That was it.
Wow.
I evacuated his epidural hematoma. He woke up. He was giving me the thumbs up on he was getting life flighted out of the country. He was awake. He was answering. He was talking.
Jeez.
Yeah, I know. I know. A sniper round directly to the dome. But he was wearing his helmet. And so, I mean, obviously, body armor and helmets and Kevlar work. They work. I mean, he took two to the chest and one to the head from a sniper. He was wearing his body armor. He was wearing his helmet. He was fine. He survived. I mean, he was like I said, he was boarding the plane and like giving us the thumbs up.
Jeez.
So, yeah, I know, right?
Like, yeah,
it works. They work. They work.
That is incredible.
I know.
So now, kind of tell me about what is your practice in Columbus? Like, what did you take from your military experience that you think maybe gives you a leg up in your private practice, or gives you a benefit,
right?
That you got in that?
Yeah. So and I don't know if it's necessarily a benefit for private practice per se, but I think just a benefit for just my overall surgical skill set is, I mean, especially having done those 2 tours in Afghanistan, having, I can make do with kind of anything, right? Just get me an instrument and I'll make it work. So that is, I'm very adaptable. And I think that's a big part. I mean, I learned that in the military. You kind of have to be adaptable. I mean, you're overseas. If they don't have something, it's not like you can bring it in from another hospital, right? So you make it work. You just figure it out. And so I have learned to do that. And I think it helps quite a bit in surgery. I mean, you get even in the most well-staffed, well-stocked hospitals, every surgeon gets into situations where they're like, okay, like, how am I going to fix this? And that is, I think that is a unique part of my skill set that came from the service. In terms of like truly my private practice, I think the main thing is the desire to do it. Right. I don't honestly believe that I think if I had not worked for the federal government for the majority of my adult life, I don't think I would have been so dead set on never working for anybody else ever again. I really do believe that. I mean, and not to say that it's necessarily, that working for the government is necessarily a bad thing, but they do control every aspect of your life. Right. I mean, my weekends were not my own. Right. If I wanted to leave the Dayton area, I had to request permission to leave the Dayton area, whether I was working or not. Doesn't matter. Right. Just I am home on my own, on my free time. If I wanted to leave, I had to ask for permission. And so that really, I mean, you spend a lot of time in that environment, and I guess you can either kind of become institutionalized and just sort of say, this is how life is, or you can do what I did, which is I never want to do this again. Right. And so that's it. That really, I think that's what drove my desire to start this clinic is I didn't want to work for anybody else. I wanted to work for myself. And I know that, I didn't want to have to ask for permission to take vacation, right? Simple little things that you don't, it just, I wanted to be able to, say, all right, like I'm going to take a couple of days here. That's my decision. I get that means that I'm, not going to necessarily earn money during those couple of days I'm taking off, but that's my decision, right? I don't have to go to somebody in some administrative office somewhere and say, hey, is it okay? Is it okay if I leave? So yeah.
Do you feel like being a private practice surgeon gives you more leverage to get things on contract at your facilities?
Yes, 100%. Because I'm not tied to that facility, right? They know that and it's all within reason, right? I can't just walk in like king of the castle and just start making demands everywhere. That doesn't fly either. But I definitely have more leverage than somebody who is on contract. And, if they ask for something that the hospital doesn't think is worth it, what option do they have?
Yeah.
They can leave the job, I guess. Whereas I can say, all right, well, you won't give it to me, but they will.
So you can take the patient to a different hospital.
Yeah,
I gotcha.
I'm going to go here. They've got an option for me and you don't. So they're getting my business now. And you do that enough times and eventually this place will come back to the table and say, okay, fine, we'll do it. These are all, especially spine surgery, but in general surgeries earn a lot of money for a lot of people. And so you start taking some of that money away because of decisions that are being made. Eventually they'll come around.
Absolutely. So I remember a number of years ago, there was a hospital in Colorado Springs and a patient got a 1-level open T-lift there.
Okay.
And they released, the patient got access to what the hospital billed the insurance. So whether what the hospital got paid on that or not.
Sure, right.
Whatever.
The charge master, at least.
The charge master,
right,
yeah. And it was $350,000 for his 1-level T-lift, open T-lift.
Yep.
And now, is the hospital going to get paid that full amount?
No.
Maybe not.
No.
But even if they get half that,
right.
It's you can see how you can use that to leverage, what you feel like you truly need.
Yes.
That's best for the patient
right.
in that instance. So I totally get that.
So right. On average, this was one of the more astounding statistics that I heard. The average neurosurgeon, right? Not even super busy, just average neurosurgeon will earn somewhere around $11 to $13 million a year for a hospital. And that's all things, right? That's not just the surgeries they're doing, but that's all the downstream revenue. That's ordering physical therapy. That's ordering MRIs. That's all of the, the financials that they can reasonably tie to that neurosurgeon. It's around $11 to $13 million annually.
Jeez.
Right?
That's crazy.
Right. And so that's why you're seeing, you see these kind of contracts being thrown around because, this is big money. This is big money. And that's why you see hospitals trying to buy up
to employ them,
all of these people, because they can control everything they do. And if you get that person, kind of locked in and you can say, hey, like 100% of your work has to be done in this hospital. You can't go to an ASC because we're not going to let you. Right.
Yeah.
So, okay. Right. But now is that best for the patient? Maybe not. Maybe not. Certainly not best for the patient financially.
No.
Right.
No.
Whether the care, sure, you can make depends on the surgeon, depends on the hospital, right? They can get equivalent care. That's not necessarily the root of the issue. But, like I said, especially in this day and age where, patients are being asked to foot more of the bill. Every year, it seems like that number increases. The percentage that patients are actually having to take on is higher and higher and higher and higher, despite the fact that insurance companies are raking in record profits. They're still putting more of the financial burden onto the patient. And I think I think you're doing your patients a disservice if you aren't aware of that and at least make reasonable effort to try to mitigate it, And so that's where, that's a big part of why I truly believe that neurosurgeons and really all surgeons should be mostly private practice because you can start making changes like that.
You can advocate for the patient.
They benefit the patient. They benefit the patient. That's what we're all here to do, right? Yes, everybody likes to, make money and do fun surgeries and all those things, but ultimately, if you aren't here to help patients, why are you here?
Yeah.
Right. So that's like my focus. My focus is, how can I provide the highest level of care with the least burden to the patient. And whether that's, coming from the facility that I do the surgery at, whether that's the type of surgery I do, maybe you get, maybe what you need is just a single level decompression, not a single level fusion, not a multi-level decompression. Maybe I view this, I review this patient's imaging and history and find like, yeah, okay, you have a little bit of stenosis above this level. I don't think that's symptomatic. We're not going to do that level. We're going to get the biggest bang for the buck. We're going to do the least amount of surgery necessary to get you back where you need to be, right? Because that's the goal. That's the goal.
And it's crazy to see because we'll see different revisions from around town, or we'll do different revisions around town with some of our surgeons. And it seems like the bigger the system that patient came from, they may be only symptomatic at one level, even if their imaging shows that it could be from other levels, but the actual symptomatic is one level. And they go to these huge institutions and they'll get T10 to pelvis, T10 to pelvis.
Yep.
And it's kind of sad because they have no idea.
Right.
No idea.
No, true. And don't get me wrong, that surgery exists for a reason. There are people who need it. There are people who need it. Do I believe everybody who gets it truly needs it? I don't. And I'm not saying that to like try to call out, not at all. But that is, to me, that should be a relatively rare surgery. And that surgery should truly be done for deformity, right? It's not like that's not a surgery you do on a virgin back.
No.
Right?
No.
A T10 to pelvis should almost never, I can't even think of a scenario in which that is a virgin back. Like that's the first surgery they're having on their back is a T10 to pelvis. Like that shouldn't.
Yeah.
Right? That is something where, okay, you've already had 4 surgeries. This is a rescue operation.
Yeah.
Like we're just trying to salvage at this point, right? And then sure, sometimes you got to go big to fix that. There aren't always small solutions to bad problems, know. But for the most part, I really do think that most patients do best with less surgery.
What do you think? So this is sometimes controversial. What do you think of, what is your perspective of chiropractic care?
Yeah, good question. So I have kind of a mixed perspective on it, right? I do truly believe there are excellent chiropractors out there, right? And I myself refer to a handful of them in Columbus. I carefully vet them, right? And I always have this conversation with patients before I refer to them, or if they come to me, and they've already had chiropractic care, right? So I always tell them, you have to really carefully vet your chiropractors, right? As I do, right? So there's really 3 that I refer to in Columbus. And I've had dinner with these guys. I've talked to them about what they do. I've really kind of grilled them on how they're talking to patients, the conversations they're having with patients, how they're recommending care. Because I think, unfortunately, and this is true in all medical fields, where there's people doing good work and then there's people doing not so good work, right? It's true across the board. Doesn't matter who you are or what you do, right? But I think in particular in that field, the gap seems to be a little wider than average. So what I typically tell patients is, if you have a guy who's getting imaging ahead of time, who's reviewing your imaging before offering treatments, that's usually a good sign. The things, kind of my pet peeves of a lot of patients that end up coming to my office, having already been in a chiropractic office, is the verbiage that gets thrown around a lot of like, oh, your back is out, twisted and out of place. Like, is it though? I mean, I have an X-ray that looks pretty normal.
And what do you mean by back?
Right.
Know what I mean? Like,
no, exactly.
What do you mean by back?
Exactly. So I always tell patients, use caution, and we all do it to a certain extent. Like you alter the language when you're talking to patients, right? I don't use words like spondylolisthesis when I'm talking to a patient. They don't know what that means, right? So you have to be careful about passing strong judgment on this, but I tell patients, if you hear a lot of very unscientific language coming from somebody, generally that's not a good sign. You know, if they're using things like your back is twisted and out of place, that's not scientific language, right? That's not explaining your problem. That's just using made up words that sound bad.
Yeah.
You know, and you know, I also, you know, I think there's also some nuance to the types of conditions they're attempting to treat, right? You know, if you see a lot of chiropractors advertising for, you know, neck adjustments for ear infections, that's not it. That's not it, right? But that being said, you know, like the three guys that I refer to, they do great work. I mean, I refer patients to them. I send patients their way. So I believe in what they're doing. I think just in general, you just have to vet chiropractors, right? And it's not that, you know, I certainly don't want, you know, a chiropractor who's listening to this to sort of feel like I'm bashing the field. I'm not. I believe in what they do. I really do. I just think there are enough bad actors in that field that you have to be careful.
I mean, you look at the outcomes of some of the neurosurgeons, right?
Yeah, true.
I would argue
you should vet all of your healthcare providers. All of them. They should all be vetted.
And the thing is, anything around the spine, the drastic lifestyle difference between a good and a bad outcome is so vast.
Yes.
That it's the difference of, yeah, I'm going to be on disability for the rest of my life, or I'm going to be able to keep building a life with my family.
Right.
Right.
Exactly.
Whereas like hip and knee guy, there are certainly big differences between the best and the worst.
Sure.
But the good and maybe not so good, it may be, you know, 6 weeks extra PT or something like that. Yeah. It's not really life altering. I always ask that about the chiropractors. I'm like, you see things like the Y strap where they're just yanking on people's heads. The
TikTok videos.
Oh, right. we put out a video with one of our surgeons around that, and we initially were like, yeah, it's like we were gonna call it what was it? It's like a pop. What was? Yeah, like people love to watch it. We're like, dude, really, what it is? It's like pop porn.
Yeah,
like right. There's like some release people get when there's like a crack.
Sounds very
like,
satisfying. Sounds very satisfying.
Yeah.
But yeah, I mean that's kind of my take on it. And I talk to patients that way too. Like I tell them when they're in the office, like, look, this is what you got to be concerned about, right? I'm you know, like I said, I send people to chiropractors, right? But I send them to the ones that I have carefully vetted. And that's not to say that those, you know, the three in particular that I refer to, that's not the end of the list, but I have carefully vetted those three. I know they're doing good work. I know they're being careful. I know they're being cautious. And they also re-refer back to me if they feel like, you know, they're not helping a patient.
Like it's out of their scope. They're like,
yeah. And to me, that's trusted care, right? That means I know that they're keeping the patient's best interest in mind. They're not just, well, come back 3 times a week for the next 25 years and I'll adjust your wallet really well.
Right. These crystals are gonna definitely help the subluxation.
You know, right. No, exactly. But, you know, and so that's how I know they're doing good work, because they know when it's out of their depth, right? They know, like, hey, look, I've tried. It's not working. This guy's not helping. Could they continue to talk that patient into coming back and getting more treatments and making more money off that patient? They could. I'm sure they could. Right. But instead, they send it back to me.
Yeah.
Yeah. Do you want to?
Yeah, I'll do refill.
You got
let's do
like
another
a third
one.
of.
I know. I poured it all. I'm like, man,
it's a 22 ouncer.
The bourbon one, something different.
Yeah. Dude, our barmaid, she's not that attractive.
So what do you think?
Dude, like this beer is fantastic.
Right?
It looks dark and I'm like, dude, you look at it and you're like, it's going to be like a fat tire or something like that.
It's like 12.5% alcohol or something like that.
7.8%.
There you go.
Yeah.
So, and it's not light.
It's not light.
Right.
It is fantastic.
But it tastes light.
It's super light. Yeah. Black maple.
Bourbon barrel.
And
that's gonna hit hard.
Where's this one?
No, that's Jackie O's.
Jackie O's.
So that's a brewery downtown.
All right.
Yeah.
Dude, look at that. Look at that. That is.
You can drink that with a fork.
Yeah.
I still got a little bit.
Jackie O's bourbon barrel.
Yeah.
Interesting.
Yep. Okay. Cool.
That tastes like I just drank a Tootsie Roll.
Really?
Or like coffee. I don't know. That is
They make really good beer too.
That's really good.
Two other ones if you want to have just a variety up there.
I'm good. I'm good. Yeah,
That's good. This is another level amazing. This tastes like a good craft beer
Sure,
from
Yep.
that we'd have out here, kind of.
Yeah.
And it's 12.6%. So that's where it is.
It kicks like
All
a
right.
mule.
Yeah. That's a middle of a blizzard.
Right. Right. Yeah.
Warming up.
Yeah.
To kind of go back to the spine side, talk to me a little bit about your understanding of the importance of building a private practice from a marketing perspective and branding.
Okay.
Like,
sure.
I feel like we see, we work across about 6 different states as a distributorship. So we have young surgeons coming into markets all the time.
Sure.
And they always have this perspective that, they came from a busy university setting or something like that. And they're like, man, I'm going to hang my shingle and people will show up in my clinic.
That is not how it works. That's not how it works. So especially for private practice, right? I think to a certain degree, employed surgeons also, right? Marketing is key for any service industry. I mean, it doesn't matter what you're doing, right? I mean, one of those 15-minute Jiffy Lube places where you get your oil changed, like marketing is key, right? You can't. Customers will not come to you if they don't know you're there, right? And patients won't come to you if they don't know you're there and they don't know you're doing good work, whether you're employed or private, but particularly in the private sector, right? Because employed surgeons and employed physicians can lean on their hospital system. Obviously, the hospital system has a bias to try to feed them, right? Because that's why they're employed. That's why the hospital is employing them, is to keep that patient population in-house and not let it leak outside.
Capture all the dollars there. Yeah.
So there is the system is favorable in that way in terms of feeding clinics. But it's still, that doesn't mean it can be ignored, but particularly for private practice. If you don't market yourself, you're dead on the vine. I mean, there's no way patients will find you, right? I mean, you could potentially, build some very niche little practice where you're kind of have sort of a very selective patient population who comes to see you and it's all word of mouth. I guess that's possible, but you're not going to be busy, right? And so if you want to be busy like I do, and if you want to grow and you want to build and you want to, get to the point where you're expanding, you're bringing in additional surgeons to your group, you're, all of these things, you have to market. You have to, other than payroll, my largest single expense is marketing.
That's
right?
awesome.
Yeah. It is number 2. It is number 2. Because otherwise it doesn't work. It doesn't work. I mean, and I think, I also do think, and again, also not unique to the healthcare industry. I think a lot of places, if you start to struggle a little bit, one of the first things that goes away is the marketing budget, right? Because it's not immediately traceable dollars, right? You're spending money and there isn't like an immediate quantifiable value to that spend.
It's not a true transaction.
It's not a true transaction. You're correct. So a lot of things, if you struggle a little bit, or you're running through a bit of a financial cold spot, one of the biggest mistakes, but also one of kind of the first sort of options is to start cutting your marketing budget. And I think that's the exact wrong response. In fact, I would increase your marketing budget. You want to try to get more customers in, and then maybe it's only a temporary increase, and you start to build a little momentum, and then you can kind of cut back on it. But cutting back on the marketing because you don't have enough patients is, it's exactly the wrong response. So yeah, marketing, video marketing, social media marketing, ad, putting out, Facebook, Google, whatever type of ad, buys that you want to do, like that's all, patients have to find you, right? And I also do think, the direct to patient marketing is huge. Patients find me.
So the patient that self-refers themselves to you through seeing a video of yours and then filling out a form and getting self-referred to you,
Yep.
how are they different than a patient that is referred to you by another physician?
Right. So, okay. So first of all, a lot of those patients are kind of at their wit's end, right? They feel like
The self-referrals.
The self-referrals,
Okay.
right? Like a lot of them are reaching out because they feel like they haven't gotten anywhere with anybody else, right? And whether that's true or not doesn't really matter. That seems to be their perception, right? Because, I mean, and it kind of makes sense, right? Like the average person isn't hopping on Google looking for a spine surgeon. They're asking their primary care doctor, or they're asking their chiropractor, or they're asking, so these people a lot of times have asked, or maybe they've even seen other surgeons, right? And they just feel like they're not getting anywhere. And then they find me, they come in to see me. So I would say on average, they're exceptionally grateful for the care they receive, no matter what it is, right? They're exceptional. They're grateful that they're being heard. They're grateful that somebody takes the time with them, because that's the other thing. That is another big part of what I believe in, especially as a private practice physician, is I spend a lot of time. I can almost guarantee more time than average, but I spend as much time as is necessary with patients. And sometimes that gets me a little behind in clinic, right? But again, because I don't have, somebody from administration or corporate looking over my shoulder saying, whoa, like you got 10 minutes with each patient, right?
Yeah.
So I take the time, I spend the time with them. I talk, even if they're non-operative, right? I take the time to show them their films, talk them through their films, talk to them about why surgery is not a great option for them, talk to them about what non-surgical options are available to them, what they can expect, all those sorts of things. So even the patients that I don't eventually operate on,
That are self-referrals.
Right? They're grateful for the care they get. And oddly enough, and this was a huge surprise to me when I kind of went back after like the first year or so and went back and really looked at my self-referred population, they end up in surgery at a significantly higher rate than the patients who were referred from other physicians' offices, which is counterintuitive, at least to me, right? You would think the patients that come from within the medical system are going to be more
worked up.
They're going to be more worked up. They're going to need something done at a higher rate, but it's actually the opposite. These self-referred patients end up needing surgery at a significantly higher rate than the patients who are not self-referred.
So this blew our mind too. We've been collecting data for almost 4 years now, and we've heard the exact same thing.
Yeah.
That the biggest difference, and the first thing they always say, the surgeons say, is they say, the patient that's self-referred to me through a video that they saw me in,
Right.
when they come into my office, they are grateful.
Yep.
And it's the difference of having your arms crossed when you walk in,
Right.
or being thankful when you walk in.
Yep. Absolutely.
And that was the number one thing they say to us. And then same thing that you said, they are more ready to advance their care
Yep.
when they're self-referred than when they are physician referred. Not to say there's anything wrong. You have to
No.
physician referred.
Yeah.
But
And the vast majority of my patients are all physician referred. But I'm somewhere in the neighborhood of like 15 to 20 self-referred patients per month, which is not a small number.
it's not a small number. How many of those are, the other side of that is, how many of those are commercially insured compared to?
The vast majority.
So
The vast majority.
same thing we see in our data.
Yeah.
Exact same.
Yeah.
We were getting 80% was what we were hitting. 80%.
Probably roughly that.
Yeah, so that's the other side that we've seen consistently across the board.
Yeah.
We're averaging about 80% commercial payers
It's
right
probably roughly that for me too. Yeah.
Insane.
They're mostly commercially insured. The occasional government payer, Medicare, Medicaid, whatever. And I don't turn them away.
No.
I don't turn them away. Particularly the self-referred patients. So I'll see them. But yeah, I would say on average, those patients they're mostly commercially insured. Like I said, I mean, it's really odd. I would not have expected, that blew my mind when I first went back and looked at the data that like these things, I mean, they're hitting, it's almost like 3 times as much. The rate of conversion to surgery is almost 3 times what it is in the physician referred patients.
That makes about sense, right? So if you're getting about 30%, 20% conversion consult to conversion to surgery. And then you multiply that out times 3, that's about right.
Yeah.
What it would come out to.
Yeah.
You're hitting 70, 80%.
Well, no, it's not that high. I wish it was. That'd be great.
60% even.
No. So I would say on average, my physician referred patients convert to surgery probably about 15% of the time.
Okay. So, all right.
And so those guys, it's close to half. Close to half end up needing surgery.
Wow.
The self-referred.
That is impressive.
Right.
Man.
I mean, it's shocking to me. Shocking. I would not have expected that.
So we noticed that in our campaigns that we run for our surgeon customers, that most of the people that self-refer have imaging even,
Right.
which is amazing. Like,
and a lot of that comes from, like, you know, that, like I said, that they're sort of at their wits' end, right? Like these are usually patients who have already been worked up. They've already maybe been told that they don't need surgery, or that surgery's too risky, or that, you know, whatever the case may be. And you know, and who knows why they're being told that, or how they're being told that, or who's the person telling them that. But, you know, they come into me and I'm like, I mean, you need a relatively routine surgery.
Yeah.
You know, I mean, I've had this conversation more than once of like, I don't see anything that gives me pause. Right. I mean, I think you'll do really well. And then they do, right? You take them, you fix whatever the issue is, and they do great. But I mean, I've found the same thing. Is these patients they've often kind of been through the medical ringer, so to speak. They've already been worked up. They've already done their conservative care. You know, they've been through, you know, 4 months of physical therapy, or they've had, you know, 12 epidural injections. And, you know, and they're just kind of at their wits' end. They're like, I don't know what to do, you know, and they come in and I'm like, yeah, let's fix that.
Yeah.
You know, I mean, you've already tried everything you can to avoid me. Right. And that's a line I use with patients all the time, you know, especially you get one that comes in kind of sort of unworked up, right? The first time they see me, you know, that sometimes can be, I run into a little bit of friction with patients sometimes with that. Cause I tell all my referring doctors, like, you don't have to do anything. I will be the easy button for you. And I think that's another big change in, you know, being a private practice physician versus a hospital employed. There's a little bit more of a captive audience when you're hospital employed, and you can sort of put more rules in place for referrals. I have no rules for referrals. Zero. And I market that way, right?
So every patient's a new patient.
Every patient's a new patient. And I market that way. When I talk to, when I'm out at a primary care office trying to build a relationship, I tell them, I want to be the easy button for you, right? I don't require an MRI. I don't require a physical therapy referral. Just send it to me. I'll figure it out. Right? I mean, I can refer them to physical therapy if I need to. So it takes 30 seconds to do, right? So, you know, that I specifically market myself that way because you have to differentiate yourself, right? Especially in a town like Columbus, right? There's a lot of surgeons in Columbus. And so if I don't present myself as a true alternative, and, you know, then it's just, they send it to me because they like my face, I guess. I don't know. But so that's how I market. I always tell them, I'm the easy button. I'll take anything, everything. I'll never say no. Right. You know, you got a guy with 4 days of back pain, hasn't even tried ibuprofen. Send him my way. Well, I'll write him for ibuprofen. I don't care. Right. But that does lead to the occasional friction with patients where they feel like they're being referred for surgery.
And you may not offer surgery at that point.
And especially if they've done nothing. You know, I mean, that patient with, and I'm just making up a random patient, but, you know, 4 days of back pain has tried absolutely nothing to mitigate that back pain, but they get referred to my office. Obviously not the first visit where, you know, I don't even know what his problem is. Yeah. I don't even know, you know, there's no imaging, there's no attempt at conservative management, there's no nothing. And again, not the fault of the referring doc, because I tell them to do that. Yeah. Right. But then sometimes, you know, and not every time, and even not even most of the time, but sometimes you get patients who feel like they were referred to a surgeon for surgery. And when I start talking to them about, well, we're going to start with physical therapy, I'm going to write you a prescription for some high dose ibuprofen. You know, we're going to get this calmed down. And they're like, well, wait a minute. I need surgery.
I need the immediate fix.
I was sent to you to fix me. And now you're telling me to go work out. Right. So some of that is, that does lead to the occasional friction with patients, but for the most part, you get these people and they're, they as long as you talk them through and you talk to them like a person, right?
Yeah.
That's the other thing too, is, you talk to them just, this is what we're going to do. This is what I would do if you were my brother or my dad or my mom, right? This is what you need. This is how we're going to get you through it. And here's the thing, if it doesn't work, then there's another option, right? Then we move on to this step. Then we get an MRI.
It's truly customized.
It's customized, right?
It's not a prescribed pathway necessarily that's
but there
preordained.
is a bit of a protocol to it, right?
There's a decision tree, but it's
yes.
a customized decision tree.
Yes, and it's customized to that particular patient and what that particular patient needs, right? And especially when you start getting into some of the, kind of the more alternative, acupuncture, we talked about chiropractic care. I refer people out for acupuncture. I refer people out for massage therapy.
CBD.
Right? CBD. Right. I obviously don't do medical marijuana.
Yeah.
But I have a lot of patients ask me about medical marijuana. I'm like, please, if that's what helps you, great. Right. So it's tailored to that individual patient and not only what they are interested in, but what is likely to benefit them. And obviously there's a bit of, compliance or patient bias within this. If I refer a patient to acupuncture who does not believe in that at all, they're never going to do it.
Yeah.
So why bother? I'm just wasting their time and my time.
Yeah.
So this all kind of circles back to the self-referred patients. They've done all those things a lot of times. They show up, they've already tried acupuncture, they've already tried chiropractors. They're kind of at the end of their rope. And so then they come in and you're like, you offer them a relatively simple solution. They're like, oh my God, this is amazing. Oh, it's not that amazing. It's just what you need, right? But yeah, I love the self-referred patients. Love it. So yeah, I think one of the biggest mistakes that new physicians, and especially new, like if you're starting a de novo private practice, one of the biggest mistakes people make is not budgeting for marketing. You have to market. Have to.
What percentage would you say of a budget should go to marketing side?
So this last year, because I actually we actually just did my end of year numbers for 2023. I was just under 10% of my total annual revenue was spent on marketing.
Wow, man. That is crazy.
Yeah, it was like 9.7%.
So what in short form, what would be your advice to a new surgeon coming out of training, starting a private practice from zero?
So first of all, I would probably not advise a surgeon fresh out of training to start a de novo private practice, right?
That's fair.
You need, especially when you're that kind of green, for lack of a better term, right? When you're coming fresh out of residency. So there is a saying in spine surgery, and I think it's probably true regardless of the subspecialty you're in, but you learn more in your first 2 years of practice than you did during your entire residency. And you learn tons during residency. So it's not like that's a slight on residency, but you just learn so much more. In residency, you're so focused on getting the job done, right? Seeing the patients, doing the surgeries, right? Making rounds, all these things, following up on labs. Most residencies, they all to a certain extent do a little bit of this, but there isn't an emphasis on how did the patient get here? What happens after, right? There's not a time budget for that in residency, right? We're limited to 80 hours a week, and there's only so much, you got to spend a lot of time just learning how to do this, right? And there's not a lot of extra time available to get all of the other aspects of it. It's, you're spending a lot of time just learning the technical aspects of this job. And rightfully so, right? If you're doing brain surgery or spine surgery, that is a technically very challenging thing. If you're doing gallbladder surgery or, anything, you have people's lives in your hand, and you should be technically very gifted to do it, right? And so you have to, by nature, you have to spend a lot of time on the technical aspects, but that then means you're not spending as much time on the before and after care, right? So residents lose a lot of that. And that's 90% of the patient experience.
getting the patient first.
Yeah, getting the patient, getting them up to the point where they need the care, and then dealing with the aftermath of the care, right? So yeah, I mean, that is there's just that is a deficiency in a lot of residencies, and understandably so, right? I mean, there's just not the time budget for it. So yeah, you learn a ton in your first couple of years of practice, regardless of who you are or where you came from. You learn so much. So I would not probably advise somebody fresh out of residency to do this. I think it would probably not go well. But suppose somebody like me, somebody who had done, a 10-year career.
Yeah.
Right? Or whatever.
Or wanting to transition out of a hospital employed
has been
position.
an employed position, has been maybe in academics, and wants to get out, wants to go to work for themselves, right? So how to start? So number one is you need working capital, because it takes time to build up patient referrals. It just does. They do not show up day one, right? So you have to have some leeway to understand, like, you are not going to turn a profit for the first several months, maybe even the first year. I mean, you got to be able to work with what you got. And part of this, it's a relationship-based business, both from the referring doctor's, perspective, but also the patient's. And some of this is just time on site, and I have actually a friend of mine who started his own private practice about 8 months before I did. And I kind of got to a point, my first year or so in practice, I kind of got to a point where I was like, I've sort of plateaued, right? I'm busy. I want to be busier. How do I get busier? And I reached out to him and I was like, hey, any advice to offer? And he was like, no, man, just time on site. Time on site. He's like, the more patients you have that are out in the community doing well, talking to other people, there's no way to speed that up, right? The more, the longer you are there doing good work, the more patients will trickle in. You can't accelerate that. You just got to be there, right? So there is some of that too. But that's my biggest advice is have working capital. Be ready to not make a ton of money, right? Because it's almost impossible to do from the jump. You just can't.
So live like a college
frugally
student for a little while.
Go back to living like a resident.
Yeah.
Right. And we all did it. It's fine. I didn't feel like my life as a resident was particularly hard to handle. But go back to living like a resident. Lifestyle creep happens to the best of us, right? You start making a bunch of money, you start buying nice things. All good. I get it. But if you're going to do this, you got to be ready to just live frugally for a little while. Maybe you don't take that vacation to Aruba this year, things like that. Right.
Yeah.
So that and market. I mean, both, like we did the video campaign. I do a lot of social media marketing. I do a lot of, Facebook ad buys and things like that. But also, I am constantly, once a quarter, I go around and, find primary care offices that will let me buy lunch for them. Right. So I bring lunch in and I just sit there. Right. I don't have anything I'm selling them. I don't have anything I'm doing for them necessarily. I just sit there. Do you have any questions? Anything I can do for you? You got any pain points I can help solve? And I've had I can't tell you how many times I've had primary care doctors when I'm in their office like that. I've had people, they've been in primary care for 25, 30 years. Like, I have never had a neurosurgeon in front of me.
That's crazy.
Right?
Like, I've
wild.
never, that's your customer base.
I've been here for 25 years. No neurosurgeon has walked into this office.
That is your customer base. That is
right.
Crazy.
Yeah. They're the ones that are driving patients to my office. So, it costs me a couple $100 to buy lunch for their office, get Panera sandwiches delivered. Like, it's nothing. It's nothing in the grand scheme of things.
Yeah.
And if I get, if I can lock down that referral pipeline, that office now sends me patients. I mean, that is the best money I've ever spent.
That's
right. And it just takes you just have to take the time, right? You just have to sit in front of them, act like a normal person, ask if there's any way you can help, right?
Absolutely.
Because that's what they need. A lot of those guys, like they just need help, right? I don't know who to send to for this problem.
Yeah.
I'm like,
throwing gum at a billboard to like
send it to me, right? And that's the other thing I always tell them. I always when I'm marketing to a private to a primary care office, I always tell them, I am your go-to guy. Send it to me, right? That doesn't mean I can fix everything, right? And that is another, I think, in my opinion, one of my strengths is I know my limitations.
Yeah.
Right. But I have relationships in the community, right? And neurosurgery is a very small community, right? We all know each other. We all know each other. Even in a town the size of Columbus, we all know each other. There's not that many of us. So I always tell them, send it to me first. Send it to me first. If it's not for me, right? If it's a problem I don't treat, or if it's something that is out of the scope of my practice, I know the guy who does do that. And I will send your patient to that guy. I don't expect you to know who that guy is, because how could they?
Yeah.
Right? They're not in that
Yeah,
community.
they're not in that. Yeah, they're not in the community.
So that, again, it's a differentiator, right? You have to be a differentiator. You have to give them a reason to send you those patients. And how often does that happen, right? I mean, how often are they sending me somebody where I'm like, oh my God, I can't. This isn't for me, right? It's not common. Maybe a couple a year, maybe. So the small bit of, for lack of a better term, like pain, right? The couple of patients a year I get that aren't really for me.
But it's really humility.
It's
humility, though.
It's so worth all of the other patients he's going to send my way.
It's not even pain, though, dude.
It's not. It's not at all. No.
That's all it is. It's purely humility.
It's not pain at all. No, it's a patient coming in. I diagnose their problem. I tell them what they likely need, right? Because I know enough to know those kind of things, right? Here's what I think you probably need, but I'm not the guy who does that. Let me send you to the guy who does do that, right? And I know him, and I'm going to send him a text so he knows you're coming. Right? We're going to bypass the whole 4-month waiting list that you would have if you just got referred, because I can skip that.
Yeah.
Right.
Absolutely. Yeah.
Right.
So kind of moving on to the next thing I wanted to ask you, how do you choose what you use? How do you choose what implants you use? There's 250 companies that make a pedicle screw now?
Oh God.
And
I didn't know there's that much.
Yeah. That's how many. And there's countless rep bros that are chest pumping their ways into
Sure.
I don't know how many Chaz Michael Schuyler the thirds come by your office and drop off a pamphlet, but
lots. So yeah, I mean, there's really two aspects to implant choice, right? And it's the implants, sure, yes, but it's also the rep.
Which one weighs heavier? Here, let me put it this way. Which one has a bigger difference between choice 1 and 2?
Oh, the rep. Yeah. Because there are some devices out there that are clearly differentiators in that market, right? Whatever it may be. Let's just pick pedicle screws for the lack of, even though that's kind of not really a good example.
Yeah.
But let's just say there's one particular pedicle screw that is just so much better than all the other pedicle screws, right? Unless that price point is completely prohibitive, most people are going to choose to use that one. It's a better device, right? But the reality of it is that so much better device doesn't exist. Pedicle screws are pretty much the same.
It's all commoditized.
It's all commoditized. And they all, it turns out if you twist the screwdriver, the screw goes into the bone, right? That's how it works generally. And so for the most part, like that individual product is not it's not that the Medtronic screw is so much better than the Stryker screw. So obviously I'm going to use the Medtronic screw. It's not that. They're the same. They're the same. I mean, they might actually even be the same, just with a different label slapped on it. I don't know. But they function in much the same way. And there is really no differentiator in the product. So then the differentiator is the person selling me the product, right? So is this somebody I can trust? Is this somebody that I know they're going to show up, they're going to be prepared, they're going to be on time, right? And it's crazy that you even have to say that.
I was gonna say that's not a standard.
Crazy that you even have to say it, but you do. Like, am I going to be sitting around waiting for a half an hour for the rep to get there so I can start my case? Right? That shouldn't ever happen, but it does.
Does it happen more than once?
Oh my God.
With
Yes.
the same rep.
No, it does not happen more than once with the same rep. It happens one time and then it never happens again. But, is that person going to be on time? Is that going to be person going to be prepared? And most importantly, and this is something that it's really hard to know until you know, is are they able to think on their feet? Right?
Outside the technique guide.
I'm doing a case. It's not going well. How are you helping me? How are you helping me get that case back on track? Right? And there are some reps that have that skill set and there are some that don't. Right? And I don't know if it's an intrinsic thing. I don't know if it's something they're taught. I really don't. But there are definitely those out there that if I get into it, I know I can rely. This guy can help. He will be an asset, right? I mean, he's obviously not doing the case. He's obviously not. It's still my hands working. But if I'm like, oh my, I mean, it happens, right? If you do enough surgery, if you've never run into a situation in surgery where you're like, I've never seen this before, then you haven't done enough surgery.
And that's a great way to put it. And the funny thing is, like, a lot of because we train a lot of junior reps in any given year.
Sure.
And the funny thing is a lot of our cues of when struggle happens is nonverbal. It's all right, we know where they are in the case.
Right.
We know what's happening that we can't see.
Right.
And we know it's taking slightly longer.
Right.
Their movements are different than they normally are.
Right.
We know there's an issue. Here's a suggestion.
They were talking earlier and now they're not.
Yeah.
Right.
You get it.
It's that kind of stuff. Right. And I'm the same way. I like to keep a relatively light and kind of jovial atmosphere in the operating room because that's how I function best, right? I don't like things to be tense or constrictive or anything like that. But when I'm in the middle of something, I stop talking, right? I'm hyper focused. I'm working on getting myself out of whatever situation I'm in and back to getting the surgery on track, right? And I have reps that see that. And I'm like, he's not talking anymore. So I'm going to shut up. I'm going to ask what he needs and I'm going to back off. And then I have reps who continue to try to talk to me about the vacations they're taking. And I'm like, you need to stop talking right now. Yeah, I mean, it's a relationship-based business. It is. And how could it not be, right? So the product matters. It does. It absolutely does. And I would never say it doesn't. But in the absence of a true differentiator of the actual device you're using, it's the rep. It's the person selling you the device. And it's the trust, the confidence, and whether or not they're an asset to the surgery, which ultimately means they're an asset to the patient, right? Because again, that's what it all boils down to. Everything is turned back. We're all doing this to help patients. And if that person is not helping the patient, I'm going to look for somebody who will.
That's fantastic. Do you notice a difference or have a preference in working? Let me ask this a better way. Do you notice a difference between the W-2 reps and the distributors?
I don't know, honestly, because I never really asked that question.
Yeah.
Right. Of what are you on? How are you paid? Right. I do know, like I do work with a handful of distributors who they kind of own their own company and they carry a variety of products. And I also work with a handful of guys who work for the company, right? The whatever it is, DePuy or Synthes or Medtronic or, and I don't know that there's like a true difference in the rep. The distributors are nice at times because I can go to them for a variety of options, right? I can say, hey, this is what I want to do. Like, especially for unique cases, right? The standard, I'm doing a 1-level TLIF. I know what I got. I know what I'm using. Boom, done, right? Probably don't need somebody kind of more specialized for that, right? I can just use I'm using whatever company this is, and that's how it's going to go. But, I have somebody who maybe had like a grade 3 slip, a little bit more of an unusual case, or, it's something that's outside of kind of the norm, right? Where I'm like, I need something a little bit different than normal here. It's nice to be able to go to a distributor and say, here's what I got. You have a solution for me here? Do you have a hyperlordotic cage that I can throw in there? Do you have something that's adjustable? And because a lot of times, the company reps, if the company doesn't have that product, They got no access to it.
And that's that. So you're saying the advantage of the distributor is them being agnostic, is them saying you bringing a kind of maybe a more complex case and them giving you a complex solution or a more comprehensive solution.
Correct. And it can be, there's nothing that says you have to use the same products in one surgery, right? So let's say I'm just creating a scenario. Let's say we got some weird case where I'm doing a 2-level fusion and, one of the levels is bone on bone, right? Very, very tiny disc space. So that would potentially be a case where I would use like an expandable cage, right? I don't frequently use expandable cages. It's not my go-to, but they do have a utility, obviously. But given that it's not my tendency and it's not what I typically do, I may go to a distributor for that case and say, all right, here's what I want to do. I want to put a non-expandable cage in at L5S1, but I need an expandable cage for 4.5 because it's bone on bone. Right. I need something that's 5 millimeters, can expand up to 12. Right. And that may be 2 different companies. Right. Yeah. There's nothing that says you can't do that. There's nothing that says if you're going to put 2 cages in, they have to come from the same source.
I would argue anatomy says you should do that.
Right.
You should customize each level relative to.
But if you go, if I'm just picking on, Medtronic, right? Okay. You go to Medtronic, the Medtronic rep, if they don't have that option for you, they don't have it. Yeah. And that's not their fault. That's the company they work for. If they can't supply the product you need, you're out of luck. You could find something else. That's the advantage of a distributor is you can really customize the solution to the patient. And most patients don't truly need like a custom solution, right? They can, a lot of times you can go in there and say, hey, I'm going to use Medtronic for you. And the whole thing is Medtronic and it's fine.
On average, how many different companies are in each of your cases?
I would say on average 2.
Okay. So your bio 2. Probably and
bio is always different. I don't typically use the bio from the device company, right? I prefer using bio companies who are bio companies.
Which is a huge advantage. They do it well.
They do it well. That's what they're focused on, right? Whereas, the putty that comes from, whatever sort of screw rep that I'm using, they just have it because it's easy.
It's the add-on. It's
the add-on.
And usually that big company third-partied it from some bio company.
Right. And who knows what that putty actually is, right? It may be 80% carrier.
Yeah.
Right? It may be nothing. Maybe
DBM is usually 80% carrier. There's some that are now up to 70, 90.
So the bio company that I preferentially use has a DBM that is 100% bone. There is 0 carrier in it.
Which bio company is that?
Isto Biologics.
Fantastic company.
Fantastic. Yes. I love their stuff.
Their bone bags,
yes.
For allograft bone, phenomenal products. Phenomenal.
Yeah. The only disadvantage to them is there are still a couple of holdout insurance companies that view their products as experimental. I don't know why. Yeah, it's just bone. It's just bone. There's nothing weird about it. It's not stem cells. There's nothing strange about it. But I think it's just that they are a young enough company that they haven't yet sort of entered into the consciousness of all of the insurance companies. And so whenever insurance companies hear a name of somebody that there's not like a 25-year track record on, they're like, it's experimental. Right? There's still a couple. Most not a problem. I use Isto for probably 90% of my cases, but there's a couple out there that deny it. They won't allow me to use it.
Crazy.
They won't allow me to use it.
You were the one that actually told me about
yeah.
their products, and I started researching them, and we now use them a lot.
Yeah, they're great.
They're great.
That's a great example of a product that the product is the differentiator, right?
100%.
Not the rep, right? Although the reps are great, but it's the product that is the reason I use it, right? Because they are significantly better than their competitors.
Would you say that is more differentiating than pedicle screws?
For sure. There's the pedicle screws are pedicle screws. There's some that maybe are good and bad that, they have little tweaks and things like that you can like or dislike. But for the most part, like I said, it's a screw that goes into bone. And if you can turn the screwdriver, it will advance the screw. right? So yeah, I mean, pedicle screws for the most part are really not differentiators. They're really not. Some of the interbody cages can be some. The biologics, though, I mean, that is a clear cut differentiator.
We've said this. We've heard the same thing that like Isto's a big one for us. I was like, that was their quality. Up until then, like their quality is unparalleled for their allograft bone. Therapeutics is somewhat differentiated just because they have
I factor.
Yeah, I factor. Like it's the only competitor to Infuse.
Yeah,
and their handling garbage.
Right,
but it doesn't matter. Like there's science behind it.
It's great.
It is fantastic.
It's great.
It has the FDA sign off to compete against Infuse.
Right. For a fraction of the cost.
For a fraction of the cost.
Which is the real.
And in cervical.
Yes.
And you can use it in cervical.
Yes. That's the real rub for iFactor is they're competing with a very expensive product at a portion of the cost. So yeah, I mean I think the biologics world does a better job of differentiating their products as opposed to differentiating their reps. I think the device world, it's probably more rep based than product based to a certain extent.
I mean, from the technical standpoint, you have to have, there's more going on than putting in a bio.
Yeah. Yes. Totally agree. But
yeah, that's interesting. So you'd say all in all, the rep is probably the bigger deciding factor for you.
Particularly for devices.
Yeah.
I would say so. I mean, it's, if the device is clearly superior, you can put up with a lot.
Yeah.
But that's so rare. For the most part, the devices are pretty equivalent. And then it's, can I trust you?
Do you have to use any devices where you hate the rep?
Yes. Yes, I do. That's okay.
That must be pretty specific.
It is.
Rare.
It is. It's very rare. But it's fine. It's fine. And I hate is a strong word.
I'm sorry.
Yeah.
Like less than murder.
I have devices that I really, really wish that a good equivalent device would come out from another company.
You wait long enough and it will.
Sure,
that's the funny thing.
Fair enough.
So kind of as we come to the end of this, I wanted to we always ask, you obviously were a Darkwater Consulting client of ours.
Yeah.
We did a bunch of videos for you. Worked with your marketing team on some of your social media stuff, whatever. Mm-hmm. What has your experience been with Darkwater Consulting?
Oh, phenomenal. I mean, I think, and we had talked about earlier, I actually had, I had done a video series with a different company prior to working with you guys. And that went fine. Like I have nothing bad to say about that particular company either. I think their videos turned out great. I think your production quality was significantly better. And overall, I mean, your videos receive significantly more traction on my site. I get comments about them all the time, right? And so, I mean, I'm planning, as I grow, as I expand, as I bring more surgeons in to my group and all that sort of stuff. I mean, this is going to be part of the onboarding package, right? You start getting credentialed while we're waiting for your credentials to go through. You get a weekend out in Denver, shoot some videos, work with the Darkwater guys. Right?
Yeah, no,
for sure.
We hope so. It's great.
You have, I mean, again, it boils down to the previous conversation of you have to market. You have to market. So if I'm bringing on another surgeon, the first thing we're going to do is start marketing that surgeon. Right?
What's the difference that you see between? And I'm not trying to throw shade at any of the other marketing companies. No. But what's the difference you see in the either experience, knowledge, or quality between Darkwater and the other content production companies you've seen?
That's a good question.
Does it have to do with, whether it's them understanding what content needs to be created? Does it
I think there was some aspect to it, although there was some knowledge from the other side too. I mean, I think you guys bring more technology to bear, right? The drone shots, that certainly didn't happen in my other, I mean, I think you guys bring a relatively unique approach to it. Obviously you're in the healthcare field outside of your digital marketing, experience. So you have kind of an insider's view from it. And that helps. I think that helps dramatically. Right. So yeah, it's hard for me to like pinpoint one thing. Like, here's the one thing you guys did that was so much better than everybody else. I think just overall the experience was better. I think the production quality was a little higher, and I think you guys did some very unique things in those videos that probably most media companies are not doing, or at least I should say most healthcare media companies are not doing. Like I said, the drone shots, all those kind of things. Yeah, it was exceptionally well received.
Oh, that's awesome. We always like to hear that.
Yeah.
And if it's ever not, we want to know that too.
Yeah, fair.
It took a lot of bad videos before we got to some good ones. But no, we loved it. We usually, like, as usual, we always do all of our podcasts will always be in studio. No one wants to sit through a Zoom call. Can't stand when people put on the remote podcast, because it's like, man, great. COVID may have increased the Zoom stock.
Yeah.
But no one wants to sit through another Zoom call.
Everybody's so tired of being on Zoom.
Yeah. Well, man, thanks for coming on.
Of course.
Super excited to see what you do in Ohio, and man, hopefully we can partner with you guys in Ohio more.
100%, yeah.
And get some more things going in Columbus. I need a reason to go to Edison. That is phenomenal.
I do not need a reason to go to Edison. I just go.
The Beer de Garde is Beer de Garde? How do you say it? Beer de Garde is phenomenal. Like, that was awesome. Thanks for bringing it.
Of course.
Yeah, CJ Berg, awesome neurosurgeon. If you're in Columbus, man, I that is 100% the most, like, you kind of break the mold of being a neurosurgeon.
I try.
Like, I find myself, we're sitting at sushi last night, or even Menudo when you first came out here. I'm like, when we sat down for Menudo that first morning, I'm like, all right, this guy's different. He's sitting down with Menudo in an area where he's the only one that doesn't speak Spanish here.
right. Yeah.
And eating Menudo. So, man, we are so excited to be able to partner with you. And thanks for coming on the podcast. And
yeah, thanks for having me. This is great. Super excited to see what you guys do too. Just in the short time I've known y'all, you've expanded, you've grown, you've moved into a studio space. You guys are doing great work.
Oh, no, I appreciate it. Axis Spine Clinic. Axis Spine Clinic in Columbus, Ohio.
Yep.
You're opening some new locations as well.
Yep. So we've got a location on the east side of Columbus in Gahanna, Ohio, and I've actually very recently partnered with Madison County Hospital out on the west side of Columbus in London, Ohio. So we're at both locations, and more to come in the future too.
Man, the other thing I would eventually like to do is be able to have you be a resource for new private practice surgeons.
Yeah.
The fact that you're a businessman and a neurosurgeon serves not only you, your community, but also your patients better.
Absolutely.
You're not desperate for cases. You're not desperate for patients. You have more patients than you need, and you still personalize it while also still keeping a healthy bottom line for you.
Yeah.
How many businesses do you have?
Right now, just the two. I've got two.
Including real estate.
Okay, three.
All right. See, that's what I'm saying.
Right.
You're going to be the guy that we put private practice physicians in front of, and we say, do that.
Yeah. And that's really, that's when I talk to people about private practice, that's kind of the angle that I take, right? So if you think you're going to start a private practice and you are just going to see patients, bill insurance company, and collect money from insurance company and make a good living, you're dead. You're dead in the water. It's never, ever going to happen. Private practice has the advantage of you can generate multiple different revenue streams, right? You can have your clinic, yes, great. And it will make money. It will make money. It just won't. There is no chance as a private practice physician that I can rival what a hospital could pay me, right? So you build other businesses, right? You bring on a physical therapy clinic. You bring on a pain management office. You bring on, you build other businesses, and that then globally, your product is what generates the real bottom line. But you can't just think you're going to show up and just be a surgeon. You have to be a business.
That's awesome, man. That is so needed for this area, for every area.
Yep.
Man, super excited to do more with you. And yeah, thanks for coming on, man.
I appreciate you having me, man. Thank you. Thank you again. Really
awesome.
Great.
Safe travels back.
Yeah, absolutely.
This is Dr. CJ Berg with Axis Spine Clinic, and this is our second podcast.